all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Avinash Gupta from Gwalior, and he's going to lecture us on flow cytometry in evaluation of hematopoetic neoplasms, a pattern-based approach. This webinar is brought to you by Mumbai Hematology Group, supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and the team Intas, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Avinash Gupta from Gwalior. All our discussants who are themselves very eminent hematologists as well as hematopathologists, and you participants for sparing your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is 8th of September, Sunday, from 11:30 a.m. Indian Standard Time, we have Dr. Malini Garg from BIMR Hospitals, Gwalior, speaking to us on chronic myeloid leukemia, challenges in clinical practice. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Akshay Mandloy from Agilus Diagnostics, Mumbai Reference Lab, Mumbai. Dr. Amrita Saraf from Sir Gangaram Hospital, Delhi. Dr. Anju Bharti from Banaras Hindu University, Varanasi. Dr. Ankur Ahuja from AFMC, Pune. Dr. Asraful Haq Chaudhary from Dhaka Medical College, Bangladesh. Dr. Deepak MB from MSMC Narayana Health City, Bengaluru. Dr. Durga Devi S from Manipal Hospital, Bengaluru. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. Gunjan Loni from Wockhardt Hospitals, Nagpur. Dr. Gurbit Singh from Jawaharlal Nehru Hospital and Research Center, Bhilai, Chhattisgarh. Dr. Neemya Thanda from North Okkalapa General Hospital, Myanmar. Dr. Hormaz Diyar Soli Sadri from Navsari. Dr. Jyoti Sawni from Gujarat Cancer and Research Institute, Ahmedabad. Dr. K. Gayatri from Lifeline Tapadia Diagnostic Center, Hyderabad. Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. Colonel Dr. Kundar Mishra from Command Hospital, Lucknow. Dr. Madhura Tinaikar Deshpande from Bharati Vidyapit Medical College and Hospital, Pune. Dr. Manjusha Ray from HCG Hospital, Bengaluru. Dr. Manoj Tosniwal from MGM Medical College and MCRI Super Specialty Hospital, Aurangabad. Dr. Manu Vimla Chandra from University of Colombo, Sri Lanka. Dr. Minu Angi from Unipath Specialty Laboratory, Ahmedabad. Dr. Myat Malle Swave from University of Medicine, Medley, Myanmar. Dr. Nidhi Jain from Zydus Hospitals, Ahmedabad. Dr. Nikhil M. Kumar from Fortis Memorial Research Institute, Gurugram. Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur. Dr. Pankaj Tantia from Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Parimal Sharda from Unipath Specialty Hospital, Unipath Specialty Laboratory, Ahmedabad. Dr. Prerna Chotmal from Bombay Hospital and Institute of Medical Research, Mumbai. Dr. Pritish Chandra Patra from IMS Some Hospital, Bhubaneswar. Dr. Pushpanjali Oja from Rajendra Institute of Medical Sciences, Ranchi. Dr. Rizwan Akhtar from SGPGI, Lucknow. Dr. Rupam Deka from AIMS, Guwahati. Dr. Ruchi Gupta from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Sanjeev Kumar Gupta from AIMS, New Delhi. Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida. Dr. Shivani Joshi from Nashik Hematology Services and Mumbai Oncocare Center, Nashik. Dr. Subhagi Agale from Grant Medical College, Mumbai. Dr. Tushar Sehgal from AIMS, Delhi. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Vijay Tilak from Varanasi. Dr. Vishwadip Khushu from AIMS, Nagpur. Dr. Yimon Tan from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Avinash Gupta from Gwalior. Dr. Avinash Gupta is consultant hematopathologist and flow cytometrist at BIMR Hospitals, Gwalior. He is also co-director of Gwalior Hematology Center, Gwalior. He did his MBBS from R.D. Gardi Medical College, Ujjain in the year 2003, followed by his post-graduation in pathology from NSCB Medical College, Jabalpur. Subsequently, he did senior residency at BMHRC, Bhopal. He also worked as Senior Research Fellow in Hematopathology Laboratory at ATTRAC, Tata Memorial Hospital, Mumbai from the year 2018 to 2019. During his Senior Research Fellowship, he was involved in various research projects and trials, including ICICL, role of circulating plasma cells in prediction of therapeutic outcome and prognostication of multiple myeloma, post-bone marrow transplant immune reconstitution, etc. He also took special training in molecular hematology, including NGS at Hematopathology Laboratory at ATTRAC, Tata Memorial Hospital, Mumbai, from April 2022 to October 2022. He worked as assistant professor in hematopathology at HBCH MPMMCC Varanasi, a unit of TMH Mumbai, for 4 years from March 2019 to March 2023. Later on, he also worked as associate professor at the same institute for a year from April 2023 to March 2024. He was involved in establishing hematopathology services, flow cytometry lab, diagnostic as well as minimal residual disease evaluation, and molecular hemato-oncology services, namely RT and RT-PCR, STR chimerism studies, fragment length analysis, Sanger sequencing, and NGS at HBCH Varanasi. He has also worked on various research projects, including PD-1 expression in adult PALL, immunophenotyping scoring for mantle cell lymphoma, and was also actively involved in teaching fellows and DM students. He is currently working as consultant hematopathologist at BIMR hospitals and co-director of Gwalior Hematology Center, Gwalior, and working towards establishing standard hematology practices in the city. He has multiple publications and has presented both oral as well as poster papers at various national and international platforms. He has special interest in diagnosis and MRD monitoring of hematological malignancies by flow cytometry and molecular hematology, especially NGS. And today he is with us and is going to lecture us on flow cytometry in evaluation of hematopoietic neoplasms, a pattern-based approach. Well, thank you so much. But before he does that, we have Intas from Intas Pharmaceuticals, who is just going to brief you out about the introduction of the webinar. And I hand over to Intas Pharmaceutical first to give a brief introduction. From Intas, anybody is there right now? Mr. Kalpesh? Anybody from Intas?
So there is no one from the Intas, so we can continue with the lecture.
Okay. So Dr. Avinash Gupta, please go ahead with your lecture. You can share this screen.
Am I audible now?
Yes, you are audible. If you can make it in full screen mode.
Yes. Is it now full screen?
Yes, full screen. Please go ahead.
Yeah. So thank you, Hematological Group and Dr. Amit for a kind introduction and for the opportunity to the MB call, sir. So on this auspicious day of Ganesh Chaturthi, everybody is celebrating this. And thanks for the audience that they are sparing time here. So as you already said about this presentation, so this is just like flow cytometric evaluation for hematopoietic neoplasm, a pattern-based approach. And why I'm going to tell about why the pattern-based approach is needed in subsequent slides. So to begin with, that a correct diagnosis is 3/4 of the remedy or treatment. So why we need this? So we all know that a correct diagnosis, if you correctly diagnose the disease, you are able to handle or treat it better. So coming to the flow cytometry, so what is flow cytometry? Everybody knows, but just for the introduction, I'm taking few minutes for flow cytometry. It's what are the parts, how we are going to deal with, how we are interpreting the antigen expression, everything, so that everybody will be able to see the maturation pattern and will learn from it. And I'll also learn from the questions and whatever the suggestions are. So what is flow cytometry? Flow cytometry is what? When there is a flow, the cells and the metry. So flow cytometry, in this flow cytometry is the physical, chemical or biological properties of an individual cells or particle which are getting measured when the cell in a fluidic system. They are coming in a single row one by one, and during this procedure, their physical, chemical or other properties are getting measured. And why we need flow cytometry? Because it allows us to do the rapid analysis of thousands of cells. And the most important thing is that it allows us the simultaneous study of we can study multiple antigen simultaneously on a single cell in a heterogeneous population, so that we can segregate each and every cell based on this antigenic expression from a heterogeneous mixture. So we can be able to separate different population of cells in a mixture of heterogeneous population, and our marrow and blood is like that. And particularly in MRD analysis, there are so many cell clusters, so many cells are there, and that time we need this sort of analysis. Because by histopathology, we can just go for one or two expressions that won't tell us about the pattern or growth or whether there is antigenic aberrancy or not. And that is the most important thing. And that's why we need pattern-based approach. So these are the flow cytometers. Right now, they are the main thing in the market: Lyrics, Cytoflex, and Canto. So what is inside the flow cytometer? If you think about, or if you go and see the flow cytometer, so flow cytometer mainly constitutes about all these 5-6 things. So first thing is fluidic system, then there is a light emission system, then there is an optical system, electronic system, then there is an information or digitalized system, and then there is an analysis part. So each and everything has its own role, and fluidics is the most important role because it is going to provide you the cells one by one. So it is just like a heart of a flow cytometer. Then once these row of cells which is coming one by one, so what does this fluidic system does? It provides a hydrodynamic focusing, and based on that hydrodynamic focusing, we will get a single cell line, or so cell come one by one through this laser light. So this light emission through the laser will excite the various fluorochromes which are attached to the cells, or these antibodies, they are attached to fluorochrome, and these antibodies are against the particular antigen where they are present on the cell surface. So these antibodies bind, and as these antibody binds, so the fluorochromes are there. So by this laser light, these fluorochrome get excited and they will emit a particular wavelength light. This wavelength light is detected, first filtered by various dichroic, bandpass, and so this is the optical system which is made of dichroic mirror, bandpass filter, long pass filter, short pass filter. And according to the wavelength, it is segregated and go into the different channels. And the number of channels is there will tell you about the number of color of your flow cytometer. It is not the color you are using in for antibodies or anything. It is about the wavelength which you are detected. So there are various channels, and this is the number. You will say 12 color, 10 color. It is like that. And from this optical system, the signal goes to the electronic system. So you can see here this photon. So there are photomultiplier tubes, photodiodes, and in recent flow cytometers, there are avalanche tubes. So this system get amplified, this signal get amplified, and it is detected or converted into the digital system by analog to digital converters or other systems. And then you can do the analysis the way you want. People can do UMAP analysis, then SPED analysis, clustering analysis, histogram analysis, contour chart, or dot plot analysis. So this is just like how this flow cytometer is made, creating a data and how you are going to analyze. And to analyze data properly, you should know each and every part, what it is going and where they can, create problems to you. So coming to the hydrodynamic focusing, if you think about what is hydrodynamic focusing, so a small video which will tell you about hydrodynamic focusing. Here you can see the plenty of cells, they are coming randomly. But if you go down, every cell is going one by one and passing through the laser light, so that every cell get detected in one way and coming through the laser light one way. Then we are coming to the scatters. So these forward and side scatters, what they will do, they will lead us to the analysis of the physical properties of cell. What is the size? What is the granularity? What is the internal complexity, etc. So I'll again go through a small video. So if you see that whenever cell crosses the path of light, there is a lot of light scattered and reflected. So this reflected light in forward direction will tell you somewhat about the size. If you see here, that the incident light is getting diverted from this surface angle. So if you calculate it properly or collect this light on a detection system, you will be able to know that what could be the approximate size of this cell. And that is what is needed for us. So what we'll do that we'll detect this forward light as it is, reflected by this single cell, and we will collect this light and we'll analyze this, create up various plots, because there is a pulse which is generated after this collection system, and the amplitude or length high or height of that pulse correlate with the size of your cells. So if you see here that a pulse is generated every time whenever the cell is crossing the light, there is a one. So if your cell is small, the height of the pulse is very low, the voltage pulse. Then again, the size increases as the cell size increases. The height of the voltage pulse increases. So here you can see that small cell, larger cell, then again more large cell. So the way cells they are coming through and passing through the laser, they are collected and their information is getting collected, and finally there is a histogram which you can plot it. So here you can see these cells, they are the large size cells, and others they are small cells. Similarly, if you think about side scatter, so what is side scatter? Side scatter is like the incident light is diverted into various directions. So in this various directions light, what happens that it is because of the, you can see that this is because of granularity and nuclear shape and everything. So again, it will tell you about the internal complexity of the cell. So side scatter will tell you how much complexity is there in within the cytoplasm or the inside the cell. So again, a histogram is plotted, and you can easily make that there is a high side scatter, low side scatter, and you can differentiate your population based on the side scatter. So individually, forward scatter and side scatter may not be that helpful, but if you make a plot with forward scatter and side scatter, that time you will be able to differentiate a population. So if you see here, this population which is green is, dim side scatter, low size, and that is your lymphocyte. Again, this is your monocytic population, and the population which is, so coming to this plot, if you see again the same thing, the population which is having low forward scatter and low side scatter and green in color, it is your lymphocyte. And again, the population which is having slightly higher forward scatter and higher side scatter is your monocyte. And the population which is having the very high side scatter is your granulocyte because of their internal complexity. So this is how you can, differentiate your peripheral blood cells and lymphocyte. And then later on, you can use the further antigens and other things to differentiate further subset of these populations. So this is the basic physical measurement of the scatter properties of the cells. So as I discussed earlier, as the laser beam light falls here, there is a reflection, and these things are detected. And so this is one of the principle of that first it will measure the physical properties, then coming to the antigenic properties. So what happens, like suppose if this is a cell and there are various antigens on the cell, and now we use these 4 antibodies, and these antibodies, they are tagged with some of the fluorochrome. So if a laser light falls on these fluorochromes, what it will do, these fluorochromes will excite, and later on they will emit a light that will be a different wavelength light, and then this light will go to the optical system, and that optical system will collect and separate this light accordingly into different channels, and the signal will get detected, and finally electronics will convert it into a data sort of thing, and it will come to us as a FCS file or LMD file, and we will analyze according with different help of with different softwares. So what are the role of flow cytometry, or what are the applications? So there are numerous applications in research field. You can do ion influx studies, cytokine. People are doing cytokine studies. People did a lot of cytokine studies during this endemic of COVID. Protein engineering to see the protein structure, whether it is distorted or right protein or coming or not. But as a hematopathologist, I usually deal with immunophenotyping and sometimes cell cycle assays. Rest, I'm not exposed to all these things, so I cannot say much about all other uses. So flow cytometry in hematology. So for hematology flow cytometry, we can roughly divide it for benign disorders, for malignant disorders. In benign disorders, we are doing for RBC, WBC, platelets. We know platelet function disorder or other platelet aggregation disorder, we are doing flow cytometry. WBC and RBC we are doing for PNH. Some of the people are doing flow cytometry for spherocytosis also, particularly Chandigarh PGI published an article also. In malignant, we are mainly doing flow for diagnostic and monitoring purposes. So for diagnosis of hematolymphoid neoplasm is not a you cannot diagnose a hematolymphoid neoplasm with a single entity. So what we need a extensive clinical history or everything, whatever, where is the lesion, what type of lesion is there, then what is the morphology. So a good morphology, then we need flow cytometry. So what is the immunophenotype, what are the aberrant populations are there. Then we need cytogenetics, as well as in this recent era, PCR, molecular NGS testing also. So this is final diagnosis comes from the integration of all these things rather than from a single thing. So in hematolymphoid neoplasm, what happens, because hematopoietic stem cell, when it matures, there is a tightly genetic regulated programs. And these are the programs which are responsible, or type genetic hierarchy is responsible for expression of antigen at particular stage. Or so that means if the genetic program is deranged or there is a genetic damage, this expression pattern will lose. So that's why we are talking about the expression patterns or pattern-based analysis. So in flow cytometry, what we'll do in hematolymphoid neoplasm, we do the diagnosis as well as classification. In this era, everybody is talking about CAR T cell therapy, CD19, and coming up CD123 therapy. There are various therapies are coming. People are trying to target CD33 also. And already we are all are giving rituximab. So again, people are measuring. So what are therapeutic targets? MRD studies, we all know, and extensively people are doing this. BLL, TLL, CLL, myeloma. Everywhere people are doing MRD based assays. And then biological parameters, so like 49D, CD38, JEP70, and various other markers. And even you can predict some of the genetic damage if you have CD25, CD66, 13, or other myeloid markers, that it is a pH or pH-like. If the BLL or things like they are NG2 positive, 15 positive, 10 negative. So you can predict MLL. In SEPA cases, they might having 34, 7, 15, 56. So you can predict a genetic damage also by certain markers. But there are a lot of interpretative things. So what are the interpretative consideration which, with little knowledge, I can suggest that we have to look for whether there is any gain of antigen. Gain of antigen means the antigen should not be there in that cell type of lineage. Suppose of CD7, presence of CD7 in myeloid lineage, bright CD7, a subset of CD7 can be there in a small subset. But if it is there, then it is something which should not be there in that lineage. Then abnormally increase or decrease expression. CD13 or 33 is there, but abnormal expression higher than the normal. So that's why we should know about the normal expression pattern. So if it is increased or decreased, whether in intensities, so that is again abnormal. Asynchronous expression means like this antigen should not be there at this stage. It is from that same lineage. Suppose if it CD34 positive cells will show you bright CD20, or CD34 positive cells will show you bright CD15 or bright 11B. That means it is abnormal. This both cannot be there simultaneously with this intensity. So this is something which is asynchronous expression. Then abnormally homogeneous or population. So if they are making a homogeneous cluster, so if you see the various patterns which I'll show you later on, there are particular variations. So some of the antigens they present in a heterogeneous way, variable way. But if they are making a homogeneous cluster, that's also abnormal. So what I mean to suggest, or what I want to focus here, that you should have a thorough knowledge of normal patterns. Then you will be able to say that this antigenic expression is abnormal for this particular stage or this cell lineage. So, and before going to analysis, every flow cytometrist should check the spillover as well as compensation, because if the compensation is not right, you may miss something. Simultaneously, if you are not checking for your spillover and your spread of population, you might call something positive, which is really not. So before starting, you should have an eagle's eye view, like the scanner view you are doing for histopathology or other things. So you should check these 4 plots, to these, and so this time plot will tell you about how your fluidics is working. If there is any proper interruption, use gap, and then that time you can say that yes, here the fluidics is not working properly. Then again, you have to see in this plot that you are not including any doublet for your further analysis. If the doublets are there, they may be positive for various antigens and they will give you the false result. Then again, this 45 versus side scatter plot and 45, this what we discussed that in this previous videos, this plot only, that forward scatter and side scatter. So here you will be able to see that population will fall in these particular regions, and 45 versus side scatter plot, which I'm going to deal with in detail in the next slide. So there are various regions in this, and various regions, the various disease population will fall in this various regions. So suppose on the x-axis there is a 45 and y-axis there is a side scatter. If you see this blue population, this is your bright CD45 and low side scatter population. That means it will be your lymphocytic population. So in this lymphocytic gate, if you will create a gate or lymphocytic zone, what are the population you may find? So they may be benign lymphocytes, B cell lymphomas, T cell lymphomas. So that means there is mostly the cell population you are getting here may be mature. Again, the next zone is your monocytic genome, which is having a higher side scatter and again moderate 45. So in this zone, you might be having monocytes or monocytic leukemias, monoblast. Hairy cell you can find here because hairy cell they are having a lot of flavonoids in their cytoplasm. So they are having a high side scatter and the cell may be having a higher side scatter. So they may fall here, they may sit here. LGLs, mast cell leukemias, because some of the mast cell they come here and some of may be here. Rare plasma cell neoplasm, because plasma cells they are not usually negative for 45, but in some cases they may show 45 and the cell population can be. Granulocyte in MDS, it is a very important thing. So what happens in MDS, the cell lose its granularity. They become agranular or hypogranular, and that's why they lose their scatter and they will sit here. So some of the granulocyte they will merge with this monocyte. So they may be here. So we should know about in this region that what is going to fall in which region. Again, in the granulocytic zone, particularly I have not plotted or not gave that shape of, people are saying teardrop pattern for APML. Normally granulocyte is there, and some of the AML with high granularity or high big cell size with granules can come up to this level. And again, the mast cell leukemia. Then a 45 dim zone, I divided into two. One is yellowish and another is red. So with the minimal side scatter and dim 45, this is the mainly zone for in a normal marrow is for hematogone. But BLL, TLL population, AMLs with no granules or undifferentiated sort of maybe you can detect these AMLs here. And then some of the lymphoproliferative mature neoplasms, sometimes they lose or they show dim 45 and the population may come to this region. Then again, the blast gate, the proper blast gate, which is in red, you can see all the neoplasms can come here. Even in this zone, there are 6-7 normal population you may find, like your NK cell subset of NK cell, your basophil, your PDCs, everything is in this region. So you have to be very cautious when you are dealing with this region and before calling anything which is disease or not. Now coming to the interpretation of antigen expression on the plots. So there are certain antigens which are exclusive for a particular lineage, like CD19, it is exclusive for B cells. CD7, it is exclusive for T cells. But some antigens, they can be there as a co-expression. So T cells can show you CD3 as well as CD7. So it is a co-expression. And when you are considering the negative things, you should consider all the negative and positive population in your analysis only. So you should have internal control. So for 34 or 117 expression, if you know that this is a normal peripheral blood and you have some of the normal lymphocytes, so before calling anything or putting any population positive, negative, you should know where is your internal control falling for negative population. So here you can say that this population, we know that it is a negative for 34 and 117. When to call it as like bright, negative, heterogeneous, dim or moderate? Because it is very important. As I told you earlier also that heterogeneous population, if it is becoming like homogeneous cluster, it is abnormal. It may be abnormal for particular antigen. So if you see in this plot, 38 versus side scatter, because grains are negative for 38, so this green population is all negative. This orange to yellowish population, this is showing you moderate. So they are the hematogones. Then this aqua population is your monocytes. So you can see this dim, negative, moderate, and these are the plasma cells. And plasma cells are the brightest for 38. So we know that when to call bright, when to call. So we are conveying some message when we are writing bright, heterogeneous, dim, or moderate. So that's why we should be aware of writing whatever the expression we are writing for a particular population, whether it is there or not, because it has its own implication. Why? Again, the same example of heterogeneous and you can see here in this plot, CD20 is proper homogeneous, moderate. They are normal lymphocytes. But simultaneously, if you see the another plot on the right side, the 20 is becoming heterogeneous. This is the case of CLL. And we all know that CD20 is like dim on in CLL. So that's where the matters. But both the things, CD20 is positive. But the way we are saying or giving in writing that this is variable and this is moderate, or this is people used to say dim to negative also. That means the CD20 expression is dimmer side. So it will convey some message that in CLL, the CD20 is dim. Now coming to the identification of blast. So as I told you, for blast identification, what we need, first thing, low side scatter, B45 expression, marker of immaturity like 34 TDT, and lack of marker of maturation for myeloid blast. Marker of maturation for myeloid series is 11B, 15, 16. They should not be there. For B lymphoblast, CD20 surface light chain. CD20 can be there in some of the mature phenotypic BLLs. Surface CD3, it is again can be there in subset or in a dim expression in T lymphoblast. But usually this is just for sake of telling you that these are the marker of maturation. They should not be there. So you can see here, this is the 45 dim population. Again, it is showing you TDT and 34. So immaturity marker, and there is lack of other no markers, like 45 is dimmer side. So what are the markers for immunophenotypic interpretation? So marker of immaturity, then lineage specific marker, and for monocytic lesion, you need to have two markers. And WHO has included SLAN and one more marker. So, but you cannot do anything. You have to mug it up. That's the only way. Nobody can explain because there are various markers coming up for every series and everything. So we have to mug it up. So till now, what is the thing which I want to tell you that what we are doing just playing a game with this flow cytometer. That we know that this is the normal antigenic expression, and now what is the difference in this sample, which we are receiving as a disease sample. So we are trying to find out the differences from normal. So how it is different and whether there are significant antigenic abnormalities or not. So it's just like a game, and we are finding more and more abnormalities and telling you guys or our clinicians friends that yes, these bloods are abnormal because they are not showing this, they are showing this, or this pattern is abnormal, this pattern is distorted, this pattern is inverted. This is the way we are doing. And to do all these things, what we should know about the various maturation path of hematopoietic cells. So we'll go to the various maturation path of all these cells. 1 minute. So coming to the next slide. So what happens, like hematopoietic stem cell, how it matures and how it go to various directions. So initially 34 negative hematopoietic cells, they will self-renewing sort of cells, but they will give rise to one of the CD34 positive cells, and sometimes they will bypass this lesion and directly convert into megakaryocyte erythroid precursor, and they will give rise to this lineage, erythroid and megakaryocytic lineage. Or they may directly convert into CD34 positive hematopoietic cell, then multipotent myeloid progenitors. Then from here, lymphoid prime progenitors. They will give multipotent lymphoid progenitor. From here you can see early T cells or pro B cells, which will give rise to B cell and B cell. Then this multipotent lymphoid progenitors can give rise to monocyte dendritic precursor also. So this is another path. So this monocyte dendritic cell precursor can come from both, coming from the multipotent myeloid series, common myeloid precursors, granulocyte, monocyte, dendritic cell precursors. So from both and they can come. So some of these dendritic cell can show you, and I have seen some of the cases where in BLL cases there is a maturation towards dendritic cell. So after having this plot, so if we see again this 45 side scatter plot. So this is from a very old article by Brent Wood, and this is the, I think every flow cytometrist starts from beginning, and every day whenever there is a need, we'll read this. So this star population is of hematopoietic stem cell, and if you see this, that as these cells mature, as we know that hematogon, they are having very scant cytoplasm, and that too agranular, so they will lose the cytoscatter. Initially, there is very minimal loss of CD45, and they will again go like this in this direction. If you can follow my this pointer, then they will become. So this is hematogon 1, 2, and then mature lymphocyte. Simultaneously, from here, the scatter of in monocytic precursor, it will increase and they will start gaining CD45, and they will fall in this direction. For granulocytic precursor, what happens that initial granules, the primary granules are of large size and they are having a higher side scatter. So they will go like higher side scatter, and again as they matures and they start gaining maturation, so they start gaining secondary granules which are smaller than, they will lose little bit side scatter and they will gain 45 and they will sit here. And the erythroid precursor, initially they will gain little bit of side scatter and they will lose 45 as well as side scatter both. So with this plot only, we'll come to know, we'll see this plot very keenly, that these are the population and this is the way they are going. So coming to the myeloid stem cells, like how it is maturing. So you can see there are various colors, the colorful life of a flow cytometrist, you can imagine. So in this plot, you can see easily that this black color population is your 34 positive, 38 negative hematopoietic stem cells. Then it converts into the red population, it matures towards that. So there are various lineages. So if you see in this U map, this is your 38 negative stem cells, then they acquire 38. So 38 is usually variable in this type of population, and they start from 38 negative to 38 positive. They will follow a path that I'll show you later on. And then some of the cells, they lose DR and some of the cell will retain DR. Some of the cell will have 13 and some of the cell will lose 13. So this pink population will be precursor monocytic population. However, this yellowish population will become your neutrophilic precursor. However, this aqua color population, you can see that this population, you can see 34, 38 here. So this population goes like this, and some of the population will have 13 and go like this, and some of the population will like this. So this population will lose 13 and will become erythroid population. And thus, if you see the same color population here, it start gaining 36. Simultaneously, if you see in another plot, that this population is how it is going in 123 versus DR plot. So this green population from this stem cell population, this DR model, the population which is started losing DR and gaining 123 becoming your basophil, and the population which is maintaining DR and again gaining your 123 becoming dendritic cell. And population which is blue in here, it starts gaining 117 and losing DR, and it has brightest 117 and they are your mast cell precursors. They will convert into a mast cell. So now coming to a particular lineage, so we'll first discuss about the neutrophilic maturation. And before going to all this maturation path, I would like to thank Dr. Gaurav Chatterjee, who gave me all these beautiful plots from his, UMAP analysis and everything. So they are doing extensive work, and when I requested him, so he shared all his plots and he agreed that I can use these slides for this presentation. So again, if you see this neutrophilic maturation, so we know, so whatever I was telling you about 34, 38 population. So if you follow this arrow and know the path of that 34, initially there are 38 negative population that will come to the 34 positive, 38 population, and then they lose both, they start losing 34, then again they lose both. So if you follow the arrow direction, you will come to know that this population is becoming like this. So these three plots maximum people are using right now in these days, because there is a lot of things going about MDS flow. So during this 1316, the people used to call it as Nike sign or right sign. So what is there? If you see that this population, which is not having 16 but having 13, is your promyelocyte. But as the promyelocyte went towards the myelocytes, they will lose 13. Then they start again gaining 16 as well as 13. And when they become mature one, and the most mature form of the granulocyte will have both 13 and 16. So if this form becomes distorted via something coming like this, or there is broken things, it's a sign of dysbiosis. Again, if you see 1311B, so again this promyelocytes, they are negative for 11B since beginning, but here they are losing 13. So this 13 from promyelocyte, it goes down. Then again cells will acquire after myelocyte, they will acquire 13 and they will mature like this. So these three plots maximum people are using for their analysis for this. And again CD10. So CD10 appears in the most mature one, and we are usually seeing in our reports, and we are writing that loss of CD10. This CD117, this is a recent marker people are using, and loss of CD117 in this most mature subset, it's like 16 positive or 16 bright subset, is a sign of myelodysplasia or dysplasia. I was not personally exposed with this 244 expression, but as the maturation path says, so this is your promyelocyte, myelocyte. So this is again sort of 13 like marker, which initially goes down, and then later mature cells will acquire 244. Now coming to monocytic maturation. So monocytic maturation, what happens that in granulocytic maturation, DR and 38 are lost. But in monocytic maturation, the cells will remain 38 and DR, and they will acquire a brighter 64, a dimmer 13, a dimmer 15, and brighter 33. So the pattern of every cell is different. So if you see, this is the classical pattern everybody knows, and every flow cytometrist follows this pattern, that 14 versus DR. If you see that the stem cell or this maturing cells, they will come like this, they'll go like this. There is a little bit loss of DR, but again, further based on the activation or the inflammatory state or other states, antigenic stimulation, this expression matters, and then they will follow this path. If you see this path of 6436, so 64 appears first rather than the 36, and it is important for people who are doing AML MRD that which antigen is coming first, because if the population is showing you 36 without 64 and having other 33 and other thing and other abnormality marker, that may be an abnormal population. So we have to think about that. Then again, 13 versus 15 pattern, if you see, whenever you are saying that these monocytes are abnormal, you have to see this plot, that whether there is a loss of 15 or continuum of 15 to 13 is lost. So these are the markers and these are the ways. And this is again 14 versus 16. It is in the recent world, everybody is doing compartmentalization of monocyte for CMML or something. And they say that in peripheral blood, particularly in peripheral blood, if you are having classical monocytes more than 14%, then it is suggestive of your CMML. So basically classical monocyte and non-classical monocytes, it depends on the antigenic stimulation or activity of cells. And if there is inflammatory state, even though it is monocytosis, then you will find some of the non-classical monocytes, 16 positive, 14 dimmer monocytes. So that in that way, you can rule out some sort of a clonality, but in these days, it's better to go for molecular analysis also. So again, I'm not much exposed about 300E, but the way the pattern maturing the cells, so initially there is no 14. So 14 and 300E, it is coming like simultaneously, they are start appearing. And this plot is again, so if you see 13 versus DR, so initially 13 is dim, they start acquiring 13 and simultaneously DR also. So DR, it is like just, they will lose a little bit of DR and again gain that. So the path is like this. So this population is not committed cells, then these are sort of your promonocytes, which are 15 brighter than the 13 and dim 13. Then there are your monocyte and there is your non-classical monocyte. So again, as I told you that everybody is talking about MDS and other myeloid stem cell neoplasm. So erythroid maturation becomes important. and people are posing various scores and everything. But if you know about all these patterns, that how this cell matures, so if you see that this is your blast cells which are committed towards the erythroid lineage, and this is aqua color, this is your proerythroblast, and they start losing 45 and gaining 71, bright 71. 71 can be there in other myeloid lineage neoplasm also. But if you see this plot here, they are having bright 71 simultaneously. They started gaining 36, and they started losing. So this is the way they in 117 versus 105. So initially they are having 117 positive, they gain 105, then they start losing 105, and then they become 117 and 105 negative. So most important pattern people say for this analysis is 71 versus 235. If you are using this plot for your MDS, and again the another plot is 36. So people say that variation or in 36 or MFI variation and loss of 71 in variability in 36 is a suggestive marker of dyspoiesis and dyserythropoiesis. So if you see these patterns, like the way cells are gaining, again 34 versus 235, you see keenly that there is no 235A. These cells are negative. Then these proerythroblasts, they start maturing. They are gaining 35, 235A and losing 34, and then they are becoming mature. And the darkest color is your mature RBC. Simultaneously, if you see this plot, 105 versus 235A, these are your myeloid cells. They are maturing towards the erythroid lineage, proerythroblast, which is your 105 brighter, and then it start losing and gaining, losing 105 and start gaining 235. So this is the pathway for erythroid cells, because again here they will lose DR. So you can use these markers and pattern to recognize that this erythropoiesis, but you should be very much aware. You should run minimum number of samples to see this patterns before committing that this is this dyspoiesis, or this is like 75, 71 down regulation, or this is overexpression. So now eosinophilic maturation, no, there is no much data about this thing and nobody is seeing this, but this recent publication, this I think not recent, it came last year only. So in this, they use particularly 49D, 49F, 11B, Singlet 8, and CD9 and CCR3. So I personally have exposure to Singlet 8, 34, CD9 during my fellowship tenure. The Prashant sir was doing some sort of a research work based on that. I really don't know whether it is published or not till now. But in this, you can see how this population is going on. This population is gaining Singlet 8. Singlet 8 is a little bit sort of a specific marker. And for you, that these eosinophils, they are usually negative for CD16. We can show you 13. Their scatter is maybe a little bit higher side. So you can see this black population here. And they can follow this path. So 11B, 49, I personally like this plot. Basically, you can see a proper both the antigens, like initially they gain 11B and then they start gaining 49F. But for me also, this is mostly theory. These are the plots which I made during my Homi Baba time. So if you see this plot very keenly, or just stay focused for some time, in this entire zone, every mature population is there. So this population which is not colored is your other population. So here your pro-monocyte, pro-erythroblast, which are 34 negative. So this population is moving like this for myeloid, and for erythroid, or for not for erythroid, or for PDC and for lymphoid cells, they are moving like this. So you can understand with these two plots that what I try to focus, that this is the maturation path for these two cells, basophils and dendritic cells. And why we need this, because basically many a times when you are doing high event analysis, that time these cells may confuse you with that that they might be MRD. So here in my further plots, here you can see easily that here is your committed stem cell, they are there. Then from here, some of the cells, they start losing DR and they are gaining 123 and they are becoming basophil. And some of the cells, they are maintaining DR and they are gaining 123. So they will become your PDC. So, and here the cells, they will lose you both the DR and 123. This population is your erythroid and other population. So in this, again, 33 versus 36 plot of 38 MNC, if you see, the way they are maturing. So in this way, they are maturing towards the sum of this population. The aqua population is your monocytic population. Then the variable 36 is there in basophilic region. Then some of the cells start losing 33 and gaining 36. This is your PDC population, and the population which is negative for 33 but brighter for 36 is your erythroid population. You can see here simultaneously with the help of 203C and 34, I made some plots the way it matures. So 117, it is losing 117 and gaining 203C. So they are like immature basophil and they are coming to the maturation. They are completing their maturation. Here, if you see the yellow color population, they are your immature mast cells. So coming to the mast cell maturation, again, what I told you that 34, 38 plots. So these are your stem cells which are negative for 38. Then they will gain 38, and here they start losing 34 as well as 38. And if you see here, then this population, it is losing 123 also and gaining 117. So this is the brightest 117. This red population is blast. This pink population, they are maturing towards, basophilic lineage, and they are gaining also 203C. So in this plot, if you see here, this is your stem cell here 34 and sort of dim 117. And then some population is going towards this. So they are becoming your mast cell, gaining 117. And some population, they are falling like this. So here your monocytic population, monocytic precursor, erythroid precursor, and other precursor will sit. So till now, we completed your myeloid series cells. Now coming to the B lymphoid maturation. So B lymphoid maturation, we all know a lot about it because we are doing BMRD since long and we are following this maturation path. But to add this, that recently from India only, there are two or three publications about stage 0 hematoma and why they become, more recognized because of this CAR T cell therapy, CD19 CAR T cell therapy. So post CD19 CAR T cell therapy, people saw that there is a stage of CD19 negative immature B cells. And initially they are confusing, then everybody, they did a lot of work, they studied a lot of things, and they realized that these are the stage 0 hematomas. So now there are two publications from India, one is by Prashant sir and one is by Dr. Tulsi Raman group. And the second publication came recently into, I think, January, February in cytometry. So again, if you see follow the pattern, so this is your red population is your committed cells class. Then this aqua population here is your stage 0 hematogone, then your stage 1 hematogone, then stage 2 hematogone. So they started acquiring 20, then stage 3 hematogone, then some of the naive cells, and then there is a proper maturation or matured B cell, which are having the maximum 20. So if you just follow this, arrow path, you will come to know that how these B cells are getting mature. So this CD30 becoming mature, and so they are losing 34 and they are gaining 20, and they are becoming the mature cell. Again, 34, 38 plot, which we discussed a lot. This plot is really interesting that in this plot, the shape is different. So initially 38 is there. Then they start at the stage of 0, they will show a little bit dim 38. Then again, stage 1 and 2 will show you the brighter 38. And then they will lose again 38 and they will become mature B cell, and mature B cell, they are having a minimal 38. So with this help, so people started using more and more B markers because they can be 19 negative. And if you are dealing with CAR T therapy samples, then you should not rely on 19 only. You should add 24, 22, and other 81. There are various publications and various guidelines for that. So coming to the T cell maturation, it is really, after leaving the marrow, T cell go to thymus, and there are very few studies for that thymus that they will tell you about the exact maturation. But in these plots, I try to find out that what is the exact maturation path. So CD1A, these cells are CD1A positive, so they are double negative sort of cells initially. Then some of them cells are started getting markers, and they will lose 1A and they will gain 45. So this is the way they mature. Again, if you see this red population in this plot, in previous plot, the red population was immature, but here in this plot, which I'm focusing on, this red and green population is the mature one. So this is the path that 1A positive cell. Here the CD1A positive cell, they are negative in CD3. Then they started gaining surface CD3. Then they are gaining CD3, but they are losing 1A. So this is the way they measure. Simultaneously here, if you see, this is the marrow plot, these two plots. So this is from the Sindhucharian's article, one of the. So here, if you see, this double positive population is going into the both direction. So this is the double positive population in thymus, and it is maturing in the both direction. And simultaneously, if you see here, there is 5, but there is no 3, and they start gaining CD3, and they are gaining more 5, and they are gaining more 3. So this is the way T cell matures. And so after all this maturation, I'll come to some of the cases, and I'll tell you where these maturation pattern helped me a lot. So with this case, first case, this is a 6-year-old boy presented to us with a complaint of fever 1 month, abdominal distension, bone pain, massive splenomegaly, but there is no lymphadenopathy and there is a history of transfusion. Outside investigation revealed bone marrow was done, but there was no flow cytometry, and they said that there was 22% blast, and they gave a diagnosis of BLL or ALL. So at investigation at our center, HBCH, there were cytopenias, bicytopenias there, but peripheral blood was normal. But again, in bone marrow aspirate, we also got something which is cells are like suspicious. And in that region, people are very prone to have, Ayurvedic medications, and they're scared to tell you about the right thing, whether they receive treatment or not. So I was a little bit skeptical whether I'm dealing with something partially treated or something different. So these sort of cells are there, and they are more than 18% INC ratio, looking like whether hematopoetic or somebody already called this is as like acute leukemia. So, and that to convince a clinician in this scenario is really very difficult. So we did a flow cytometry. And on flow cytometry, what I got, there is a 45 dim population. And as we learned that 45 dim population, the BLL cells can be there. So as I told you, I just look for the time plot, and my fluidics is perfect. I'm not including any doublets. I just took the proper viable cell populations. And then I get it like 45 dim population, and I'm getting that population. And I think that it is 10 positive, 20 negative, dim 20, and whatever it is. So I thought it is a BLL, and just like, but again, we used to do this pattern-based analysis. So we made different plots, and we see the pattern. So when I saw this pattern, like if you see that 34, 38 plots, so these are the early stem cells. They are 10 negative. They are non-B precursor. They are usually myeloid cells. Whereas this orange population is hematogone 1, hematogone 2, and they are following the normal maturation path. And when I compared with my normal thing also, then it is like properly, these cells are properly following normal path. And it became very difficult for me to say that this is a positive. Then I discussed it with some of the senior persons. And again, so I was not convinced. I think there were 2 JCs held for this. And so I gave a descriptive report with this mentioning that it does not reveal anything, which I can call as acute leukemia, but these are the populations are there in the one sort of population. So a descriptive report was given to the patient, and we were waiting for biopsy reports, and biopsy saved me. So on this biopsy, there was diffusely replaced by the histiocytes, and a possibility of storage disorder was considered. So I requested to histopathology team, so they shared their images, and I saw this like completely packed marrow, and these are like some sort of a filled macrophages. I'm not having the IHC slides, but these are the slides which I got. And then we sent a sample for DNA also in between. So DNA analysis, that time we were sending for all the molecular tests to Mumbai only. So from there was no mutation, nothing like that. And I was thinking that whether I missed something, or because if this sort of picture is there. So I asked my team that do all the slides, stain all the slides, imprints, whatever the material we have. And later on, I also got these sort of macrophages filled with that. So later on, I realized that yes, sometimes you have to stain all the slides. And we search for some of the literature whether there is earlier things also. So there is a very old article where they mentioned that in Gauchers also there may be expansion of hematogones or any condition in pediatric age group. So altogether, this is a case, and the message from this case is just don't overlook the things. If there is something, spend time, be cautious, be harmful to you or somebody else. So coming to the next case, this is a 2-year-old male with this case is diagnosed at our center only. We only diagnosed it at HBCH. And this case was positive. So we gave a diagnosis of acute myeloid leukemia with monocytic differentiation. Basically, mostly the monoblasts were there. So KMT2A fusion was positive in 90% at cytogenetics at baseline. Post-induction marrow was done and sent to us. So what we found, I found around 33% immature cell. They are mimicking like blast, but I thought, okay, yes, marrow is not in remission. As we know that this case was diagnosed as acute leukemia, so we have different panels. So I put the AML-MRD panel. And when I saw this AML-MRD tube, what I am seeing is like there is a bulk of population is like huge population in this 45 DIM 38 MNC plot. I was thinking how much population is. So initially I thought, yes, this patient was looking like the blasts or immature cells were there in marrow. So it may be not in remission sort of. But when I see this plot, 13 versus 34 versus 19, then I thought they all are hematogone rather than myeloid blast. They are hematogones. So whether it is the marrow is not in remission or in remission. So the question was like that. Then I did the analysis and I found that there are like myeloid blasts are not looking that abnormal. Some of the monocytic population is abnormal in that. Sorry, I'm not having that morphology image, but seeing this, so I just put a BMRD tube also. So on BMRD tube, I see that there is a huge bulge in this 45 DIM region. Everything is fine, 45. So you can separate this population. This population is 20 negative. So again, we did our analysis, and in that pattern-based analysis, what we are seeing that this should mature like this. But 34 positive cells, which are 19 positive, why they are coming like 10 negative? And we know that this case was MLL positive, and MLL usually have 10 negative. So now the thing is this abnormal population. So what happens with this? So is this a wrong sample? So what is the problem? Where is the problem is? So we ran 2 MRD, so we finished the sample. We have no other option. We asked the clinicians, and they said that they are very sure the sample is from the same patient. So what we did, we go back to the previous diagnostic one. And at the baseline flow, we see that this population is sitting in the monocytic zone. This population, nothing is in, I think bulk is in the 19 positive region, 10 is negative. So we are thinking like, yes, this population is properly. We are having a template-based analysis. So there we are doing, as I show you that DR versus 14 plot, 13 versus 33 plot, the pattern, how this stem cell matures in both the direction. And again, the 11V versus 15 plot. So how these monocyte matures like this, the granulocyte matures like this, and monocyte come here. So it is sitting in properly monocytic zone, the plot, which is the location for monocyte 11V versus 15 plot. And they are showing me variable 13, 14 is there, 36 is there. So it is a properly, and MPU is very dim. And on cytoplasmic team, MPU is not there, dim sort of MPU or in a very small subset. 79 is not there, CD3 is not there. So what is wrong? And again, we go back to our, we have another tube also in AL only where we have the pattern-based analysis, and we saw. So when we are seeing this plot, there is a very less population, less than 0.1% of the entire population, and this population is looking suspicious because it is coming 19 positive and 34 positive. So usually in myeloid neoplasms, hematogone decreases rather than they are there. So we were suspicious. So what we did, we just enhanced this population. So we make it large and we started studying. So this population, which is black, we targeted this population. We started seeing this population. So this population is again 19 positive, 34 positive, 10 is in very small subset sort of. And if you see here, this population is 38 dim, 34 positive, 123 positive, showing 86 variable, and 34, 38, and 45 both dim. And it is the same phenotype which we were getting this in this post-induction time. So this was a thing to discuss. So we make a final report, but before that, we discussed it in the intra-departmental and interdepartmental discussions were held, and we gave this report. So we told them that there are morphologically this thing, but this analysis is revealing only 0.65% of abnormal monocytes. But they are showing an abnormal B cell population, and this population, the phenotype of this population is matches with the population, a small subset which we missed earlier. And at this time also cytogenetics was performed, and it shows about 30% cells with this MLL positivity. So the message from this case that you may miss your dice, but you have to go and find it very keenly and go and check everywhere. And if you work hard and you will see your population, you go and get every population and think about that and go for the patterns, you will find your dice. So with this presentation, my take home message is like diagnosis of hematolymphoid neoplasm is always a multidisciplinary approach. Whenever you are doing the analysis of flow cytometry plots or rare event analysis, don't be in rush. Spend some time, look for the hematological immunophenotypic aberrancies, abnormal maturation patterns, because they are the one which will save you. And always correlate with other modalities, and if required, review your own findings. Like in my case, I missed something on aspirate slide when what I got later on after staining all the slides. So this is the message from all this presentation, and happy Ganesh Chaturthi all. Thank you.
Thank you, Dr. Avinash Gupta, for that fantastic presentation. Very good learning from you. Thank you. And beautifully you showed the last two cases, case 1 and case 2. It was an eye-opener for all of us. Thanks a lot. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Avinash Gupta. In the meanwhile, we'll take some of the questions from the audience.
Yeah.
Yeah, there's no other questions. So anybody in the discussion want to ask any question?
Dr. Avinash, are you able to hear me?
Yes,
Yes, sir. Yes, sir.
Vijay Tilak.
Dr. Avinash, I have just this thing that you told about hydrodynamic focusing. Now there's been a recent concept of acoustic assisted
Yes.
hydrodynamic focusing.
Yes, sir. That is a new concept. The tuned flow cytometers, they are coming. So what they are doing, they are generating acoustic waves, and based on that, they are doing that hydrodynamic focusing. So rather than using the sheath fluid and two fluids with the differential pressure, they are creating. So ultimately, you have to create a single cell file. Your cells should go one by one in a linear fashion, not in a random fashion. Otherwise, you won't be able to detect the scatter properly and you will miss the finding. So the purpose of this analysis or hydrodynamic focusing is to get a single cell file one by one, which will cross your laser one by one, so that you will get a proper data and proper light excitation and emission.
Right. And other thing is that you very beautifully depicted the normal maturation, and it is very important to compare them with your sample so that you don't underdiagnose or overdiagnose. There were some these diagrams in Todd and Stanford regarding the normal maturation, how they are maturing, how these neutrophils are maturing, and I
think
feel it to be very helpful.
Yeah, I think you are talking about the Woods. So Brent Woods chapter is there, and it's the same thing. So the 45 plot which I showed, I told you that time also that plot is from Brentwood's earlier article from 2004. It's not today's article; it was 2004's article.
Yeah, yeah.
So people are studying this only. And there is an article from Loken Group in 2004-5 only. They depicted the maturation path of all the neutrophilic series, how they mature. The only thing is we have to incorporate all these things. The take-home message from my slide, the last one, is that you have to sit there and see the entire thing. What we are doing, that we as a fellow or as a resident, we are in so much hurry that we are not dealing with. The moment we'll get the blast, we'll say it is acute leukemia. We are not giving a look for the monocyte abnormalities, erythroid abnormalities, or whatever they are.
Yeah, yeah.
So that's what the purpose is. That basically I burned my fingers, so I just shared my experience.
Right. Thank you. Thank you.
Thank you, sir. Dr. Upendra Sharma, your question, please.
Thanks, Dr. Avinash, for that wonderful presentation. So,
Thank you, sir.
very basic question: how we can differentiate between blast and hematogones on flow?
Sir, blast and hematogones. So first thing is like 45 dim and low site scatter. Then we have to have this maturation path. So at least 6 to 8 markers you have to use, because if you are using in the post-induction samples, there is like post-induction immunophenotypic down regulation and up regulations also. So after induction, your B blast, abnormal B blast may lose 34, may lose CD10, they may gain 20 and 45 also. So there is the person who is dealing with all these things, he should be very much aware about all the post-induction changes and these changes and these patterns. So that's why I showed you some of the patterns which are recently coming up after this CD19 therapy. So initially we were aware about only one thing, which is like stage 1, stage 2. Now there is one more thing, stage 0. And in 2016-17, one Fusion Group article, they showed 7 types of hematoma. So it is the number of marker you are using, the pattern you are using, how you are comparing with your normal sample. So basically, like you can see the 10-20 plot, you can see the 45-38 plot, you can see the 19 versus 45 plot. So there are various maturation patterns which you have seen, which I showed that there are particular patterns. Based on just 45 dim and 19 positive is not your hematoma. That may be normal, that may be abnormal. That time you have to look for some of the aberrant marker and the maturation path, whether they are following normal maturation path or they are following abnormal path. They are missing something.
Thank you. Dr. Amit, can I ask another question?
Yeah, please go ahead.
Dr. Avinash, the role of flow cytometry in the diagnosis and risk stratification of myelodysplastic syndrome.
So risk stratification, so there are various studies are coming up, but still WHO has not incorporated it is in the diagnosis requirement, but they recommend. So if you have a good flow cytometrist and you have a good panel number of antibodies, that time you can go there. So what they're suggesting that you have to do the single cell analysis for that. First, you have to do the 34 precursor or precursor cell analysis. You will check whether there is any antigenic aberration, there is any deviation from their normal maturation path. Then you will see the neutrophils. So what is the scatter? As I told you that in this MDS, the scatter will go. But you have to take care that the sample should not be more than 48 hours old. If the sample is more than 48 hours old, that time the scatter they will lose normal neutrophil also lose the scatter. So that time, then again, there are various guidelines and algorithms, scoring systems. The most common is Ogata. People are using. And then another is recently came up, which is IMDS. So in 2023, this Kern group published that article, Volker. So in that they are saying, so you have to focus on 34 positive cells. So first myeloid precursors, then loss of B cell precursors. In myeloid neoplasm, less than 34 positive B cell precursor will be the less than 5% of all these 34 positive cells. So there is a loss of B cell. Then 34 positive cell myeloid cell, they will show you some of the aberrancies or they will deviate from their normal maturation path. Then these neutrophilic patterns, which I showed you 13 versus 16. That's a typical Nike pattern sign. So there are aberrations or there may be breakage in that part. Again, you will see the monocytes. So monocyte, again, monocyte 13, 15, DR14, they will show different aberrations. They can show you CD2, CD56 and CD7. Score and other score. So there you will see the expression pattern. So how much is the variability? What is the MFI of CD36 expression, whether the CD71 is downregulated or not. What is the pattern with CD71 and 235? So if you see all these patterns and you are aware about all these patterns, you will come to know that this is not normal. And simultaneously, you have to correlate with your clinical picture also and morphology also. You cannot just say based on flow. But yes, if the patient is having cytopenias, the marrow is hypocellular, these things are there, then you can correlate and you can calculate. The difficulty comes when it is a low grade, but the markers and the experienced people, they are able to say that, yes, this is a thing.
Thank you.
Thank you, sir. Dr. Ankur Ahuja, sir, your question.
Good morning, sir. Thank you, sir. Very excellent presented, Dr. Avinash, and especially those
Thank
cases. I'm sure, like you, we also have dealt with those cases, and they are learning points actually. So my question is also as a basic one. We actually frequently deal with problem in the T lymphoid neoplasms, TNHLs or TLLs, especially when the samples comes from the mediastinal mass. So can you help us? Can you just guide us how to approach and how to differentiate between the benign versus the malignant, especially when the samples are from the mediastinal masses?
So, sir, especially if you are not pricking the mediastinum and you are just taking the pleural fluid. So what is the dictum is CD1A positive cells should not be outside the thymus.
Yeah.
One thing. So if the cells is showing CD1A, that means they are abnormal. Then there are various paths and everything. So TLLs can show you bright 45. But if you see the maturation path, so if you see the various combination of 5 versus 7 versus cytoplasmic CD3 and surface CD3, you will come to know they are not normal. A small subset of CD7 negative, CD5 negative can be there, but they should not be in higher percentages. So if you are dealing with a huge malignancy, there is a mediastinal mass, patient is in ICU having respiratory distress and everything, and you are getting a bulk of T cells, that too they are having down-regulated 7. Only thing is sometimes EBV viruses and other viruses will show you a CD7 down regulation, but that you will come to know because there may not be other abnormalities. So patient's clinical history, clinical picture, you might be having radiology along with you. There may be a huge mass which may not be there in every viral infection. Then the patient is having effusions, bilateral effusion, and then if you are doing pleural fluid flow cytometry and you are getting all these things, the things will be sorted.
Thanks. Thank you.
Thank you, sir. Dr. Amrit Saraf, ma'am, your question, please.
Thank you, Dr. Hello. Thank you, Dr. Amit. It was a beautiful talk and I really enjoyed it. And since we are so much interested in flow cytometry and we do it on the regular basis, I would like to make a comment also, and I have a question also. Like, especially when we deal with the fluids, when we have fluids coming for flow cytometry. So, Dr. Avinash, what is your comment on that? Because if we don't do the flow cytometry on the same day, there are very high chances that the next day these cells die and we are not able to get the good results. So what exactly you will suggest, like for the fluids which come in the late evening or in the afternoon and where they want an urgent diagnosis, but there are challenges in running the flow?
So, ma'am, I have not published, but if you use RPMI media, it will help you. So if you equally mix this sample in RPMI media, you will get cells. But definitely for CSF, you cannot do this.
Yes.
Because the sample is less and sometimes cellularity is not like that. So in CSF sample, most of the time, the lumbar puncture is done by some of the residents. They are in hurry. So mostly they are traumatic. There may be peripheral blast. So simultaneously, we have to correlate with peripheral blast, peripheral blood smear also. So whenever I used to give negative or positive, I'll always consider the same day peripheral blood smear. Because if there are RBCs and peripheral blood is showing me the blast 4%, 5%, then I cannot say that this blast is coming from CSF or peripheral blood.
Right.
And RPMI media helps, it prolongs the life of that sample. So if you are having sample from pleural fluid, you can easily use RPMI and you can leave it for 12 to 16 hours very easily, even up to 24 hours. But better to do it as soon as you can.
Right, I understood. And then for tissue also, we have used RPMI, and like for flow cytometry, like on lymph node, on thyroid, that also works very well. But then one has to be very careful in terms of using the strainer and making it
Yes.
a smooth sample for a
Sample.
single cell running.
Single. Yes.
Yeah.
There
So
should be no clot, no thread,
no
nothing
clot,
like that.
nothing.
The
Otherwise,
filtration should be very proper. Otherwise, it
right,
will choke
the flow
your
is
system.
at risk.
Yeah.
Right. So, and also I would like to make a comment like which you highlighted, that one has to see the cells very carefully, and nobody should take a decision in hurry, because sometimes, again, because of pressure from the clinical side, you just want to, they want an answer from you. And then of course you can't change it next day, no, that it was not the correct thing. Because recently what happened, that we got a sample and there were it was in the peripheral blood, and there were suspicious looking cells. And in Delhi there are a lot of viral infections going on, so sometimes the cells were looking doubtful. And then one of my colleague unfortunately thought that they are looking like blast, and called them blast. But when the barrow was done, so it was like we were so relieved that they were not blast, but they were reactive lymphocytes. They were B and T showing activation markers. In fact, today only I have released that report, and once you shared this, I am also sharing this point, that we cannot imagine that once the morphology is pointing towards a blast-like morphology, they are going to be blast. They could be something else. So I fully agree with what you have highlighted, and it was a beautifully taken lecture with so much of information. Thank you so much.
So, ma'am, I also had that same experience with patients with viral infection with cytopenias came,
Right.
and Downy 3 cells, they
Yes.
mimic like anything, and the clinician is saying,
Yes.
and your resident is coming to you, they are, yes, sir, this is blast, and that time you also got confused, and then you have to release the
Right.
report, and these cells, they will show you the down regulation CD7 and 5, and they are little bit
Right.
of activated CD8 positive cells, and that time you are in like, oh my God, what to give? So
Right.
that time, I think we have to talk to our clinician, be just in
Definitely.
pace. Yeah. So that is the only answer, that we have this flow findings, because once you run the flow, that file is with you for your life. So no
Right.
issues, you can share that file. And I don't think so, okay, there are a problem. You can share the file with your colleagues.
Yes.
So that
And
you can have an answer. So I
and
think,
I think yeah.
so
Sorry.
yeah, ma'am.
No, I was just saying, like, sometimes the history is also not complete. So I think one should have a patience, and then we have to sort of, I mean, I think my clinical, colleague, they should not mind it, but sometimes we have to push them and we have to find out the history. It's like by pressurizing them that please tell us the exact history so that we are able to offer you a correct diagnosis. So that also matters a lot, but of course, morphology has its limitation, and one need to be very, very careful before we say anything, because words once delivered cannot be taken back.
Right. Okay. Absolutely.
Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. Dr. Avinash, to the same note, if you are doing a CSF flow, what should be the processing time once the CSF is collected?
We will try to run it as soon as possible as it is received in the thing, and we will prepare the slides for morphology. But if it is coming late, so we usually have this thing conveyed to our clinician that please don't send CSF flow after 2 o'clock unless it is emergency. Because ideally CSF fluid should be processed for everything within 3 to 4 hours.
So
they are depleted in glucose and everything. So your cells will start dying. And for that also you have to centrifuge the sample. And once you centrifuge the sample, these cells, normal lymphocyte may mimic like blast. And if they are degenerating, then anybody can commit a mistake.
True. Thank you. Dr. Akanksha, your question, please.
Yeah, thank you, Dr. Avinash, for the very informative talk. So my question is regarding, how flow cytometry, on the basis of flow cytometry, can you differentiate pH positive ALL from a de novo blast crisis of CML? Or is it always that it has to be combined with the morphology of the bone marrow to give the final report?
See, it is a still debate going on based on this, that if a de novo pH positive is coming. So here the morphology helps. And if you do the flow also, and if you are doing every cell analysis, suppose on flow you are getting basophil also, other you are having myeloid precursors also, the other direction cells going in other direction also. So matlab you means I mean to say that you are having a heterogeneous population in your flow also, and that time only 20% blast, 30% blast, 40% blast, and then left shifted myeloid population. There is basophilia, eosinophilia, other things are there. That time you can comment. But if the blast percentage is 90 and it is de novo, and sometimes patient may not give you the history, or sometimes there is no splenomegaly also, that time nothing can answer exactly. It's always the clinical continuum which can help, that whether the patient is having the same symptoms since last 1 month or it is just appeared. There are particular, there is a series, I think, about this myeloid neoplasm. They studied 10, 13 cases. So they gave some criterias, but exactly I'm not remembering this time, that can help. But you cannot be sure just based on the flow cytometric findings that this is a de novo blast crisis and this is a CML blast crisis if you are not having a history. If the presentation is acute, then it is challenging as far as my knowledge concerns. Somebody else, if they know, they can comment.
And what about the CD25? Like that is a marker for
CD25
BCR
will be
I think
there.
it's a,
CD25 will help in telling you that this may be pH positive or pH like, but it won't tell you that this is de novo or this is coming from, you know.
Sure. Fine. Okay. Thank you so much. Yeah.
Thank you, Dr. Agninsha. Dr. Akshay Mandloy, your question, please.
Hi, sir. Nice hearing from you after a long time.
Yes,
Sir, do you follow any kappa lambda light chain ratio, a cutoff for that to call it clonal?
I think I taught you all. The way we used to analyze is the way we did, we worked together. Okay. So we never went on the first plot with kappa lambda. Before going to kappa lambda, we have at least 20 plots. Then we are segregating the population.
Let me just elaborate the plots to you.
Yes.
We are getting around 30% B lymphocytes. They are showing a near normal expression of 20, and rest all the marker expression is normal. Just the problem is that the ratio is slightly deviated.
Slightly deviated means how much? And that too, what is the presentation?
2:1. Kappa to lambda is 3:1.
No. Then
and
you
no
have to think.
lymphocytopathy.
Then you have to think about other situations. What is the reactivity going on? What are the clinical situations? Is the patient is having any chronic hepatitis B, hepatitis C, HIV? What is the status? So in these cases, the clinical history is very important, because some of the cells, they are getting activated and some of the cells, they will take part. So basically in ours, whatever the setup is there, in our scenario, 2:1 is the common finding. Just based on the 2:1 ratio of kappa lambda, I won't say that this is clonal. Somebody can say that is their call, but I will try to find out some antigenic aberrancy, then I will take a call. And that too, because kappa lambda staining is it's a thing, you know. So what you can do again, you can give a wash, take the sample on 37 degrees centigrade for half an hour, and take a history of other viral infections and other, whether the patient is having a splenomegaly, particularly for endemic or tropical splenomegaly.
Okay. And one more question. So we are having blastoid morphology on peripheral blood. Platelet count is around 1 lakh. On flow cytometry, we are getting a heterogeneous CD45 expressing population, which is co-expressing CD19 and CD10. CD20 is around dim to moderate. Negative for 34 TDT, kappa and lambda. Whether to call it a BLL with CD20 expression or a high-grade B-cell lymphoma.
See, kappa lambda expression is not coming, right?
Yeah, kappa lambda also negative.
There is no TDT. So then again, you have to go through the history, that what appeared first. Whether it was a marrow disease, what is your, uptake, what is the clinical suggestion, whether they are suspecting DLBCL, because DLBCL can also show you down regulation of all these things. Whether the cells are 10 positive, what is the 38 presentation? And if you are doing acute leukemia analysis, what are the other aberrant markers like 123, 86, 10 versus 20 plot? So you have to do this before calling anything like that. Otherwise, you can just call it as a high-grade hematolymphoid neoplasm. And basically, if it is a very high-grade hematolymphoid neoplasm, I think Dr. Amit can answer that in these scenarios, how you are going to treat if there is a, this sort of a discrepancy that what to call it as, that DLBCL is becoming like that, or it is showing markers like that, that they lose their expression of kappa lambda. So how you are going to treat? Because I don't think so that in these sort of scenarios, there is a much difference in the treatment guideline.
So definitely, yes, for high-grade DLBCL, the treatment remains the same, except for one thing, if the patient has got double hit or triple hit, then the treatment is different. And second thing, if the patient has got a primary mediastinal B-cell lymphoma, then the treatment is altogether different. Baki, rest of the treatment remains the same.
So, but the primary B-cell lymphoma, the presentation is different, the histology is different, there is sclerosis, there is a pattern of banding. So the histopathology is altogether different.
True. Absolutely.
I would like to say one thing. Sorry to interfere. That TDT should also be done on a tissue biopsy, because not all the time the flow is able to show TDT. So it's better to confirm on histopathology also. I mean, just a suggestion. It may or may not come positive.
Agreed, ma'am. Agreed.
Thank you.
Thank you, Dr. Akshay. Dr. Meenu Angi, ma'am, your question, please.
Very nice presentation, Dr. Avinash. I have a question like ploidy analysis plays a very important role in ALL. So can this be incorporated in the same way for myeloma? Is it possible?
You can have another tube with a few B markers, and you can just permeabilize the reagent. I used to pick sperm through. You can use you can use with 3-4 markers. You can separate the population and there are few recent articles also. And one of the article from TMH Mumbai only, where they just showed the endo reduplication based on flow cytometry, which was not picked up initially by cytogenetics. So that protocol can be followed.
Okay. Because that can be helpful, because in those cases, sometimes.
But a single channel you have to block for that, because you cannot use other things. But you can use 4 or 5 markers. So you can use a just separate tube into your AL panel for, and in that thing, you can, to separate the B blast, you can use 34, 10, 19 or 38. And again, you can use some viability dye and lymphocyte, so that you can have a ratio of lymphocyte and a blast, and you can do the ploidy analysis further.
Thank you. Because that is very helpful. If all the centers start including ploidy analysis in the acute leukemia diagnosis, that helps a lot, because hyperdeployed ALL usually don't grow like this karyotype.
Yes, but right now people are doing all the molecular stuff. And if you are doing all the molecular stuff, so maximum people, they are reporting copy number alteration. And if they are reporting copy number alteration, you will get everything done there only. So if people are doing fusion analysis, they are simultaneously with the sort of different pipelines, they are doing analyzing the CNAs also. And then if you are having an integrated lab and you are doing everything in that in-house, or you are sending to a person who is doing everything, that time it can be helpful to you that you may get a result from a single lab. So basically it should be an integrated report from one center, but in India, the things are different.
Okay. Thanks a lot.
Thank you.
Thank you, ma'am. Dr. Manjusha Rai, your question, please.
Hi. Thank you, Dr. Amit. And Dr. Avinash, thank you for the lovely talk. You covered everything very well, the normal maturation patterns. I was just wondering, do you have anything on NK cells, normal patterns which we can follow, or other markers apart from the standard 7, 56, 16?
Yeah, there are markers. You can use 244, you can use 94, you can use KIR antigens. So there are papers based on that. I cannot include everything for this thing, So if you make a plot with a high-end analysis or your BMRD plot, and you will put the CD 56, 7 and 34, and you will make, after cleaning the entire population, you can make a plot with 34 and 56. You may find a small chunk of population, they are going towards the 56. So they may be your NK cells. right? But to call it as, you can use 244, 194. There are different antigens available for NK cell also, and NK cell maturation is something all towards different thing. It will initially have 117 also. So NK cell ontogeny is altogether a different thing, and you need a different panel for that. There are various publications regarding that. You can follow that and you will come.
Okay, thank you.
Thank you. Some questions are there from the audience. Dr. Yi Montent has asked, what is the minimum essential panels to diagnose T-cell lymphoma?
Minimum essential panel. So basically it is a difficult one. What they want? If you want to conclude the diagnosis, you have to put additional tubes according to the finding you are getting in your first tube. Just based on 5, 6, 7 markers, you cannot conclude your diagnosis. You have to have a panel. So in the first go, you can go for perfor. You can't go for perforin. You can't go for ELK. You can't go for CD30. You can't go for CD26, 45, RA and RO. So there are various antigens we know. So what we do when we are getting abnormal T cell population and we are suspecting that, then we'll go and see the morphology and clinical picture, and whatever we are suspecting, accordingly we will choose an antibodies and we'll make a custom tube and we'll put it. For clonality, recently the marker TRBC1, which is coming, which is very helpful. Even you can use it cytoplasmically. There are a good number of papers citing that they used it and they are getting the abnormality or clonality. They can use TRBC1 along with
Sorry, I just missed your last part actually.
So I was just telling about TRBC1, which can be used like a kappa lambda.
Yes. Thank you. Another question from Dr. E. Montent. What are the pitfalls in assessing leukemia MRD?
So if we are not aware about all these things, you can miss. If you are not aware about immunomodulation, you can miss. If we are not looking at our instrument settings and other cocktail preparations, we can miss. And if there is some emerging population and we are not thinking about it, as I showed in that last case, so we can miss the things. None of the diagnostic test is 100%. There are chances of making mistakes. It is just like by doing, you learn something, and definitely everybody is doing some sort of, sometimes they are missing something.
Thank you. Another question from Dr. Mamta Yagrup. In the last case, what you showed, hematocones in the post-induction marrow, were they ruled out as they appeared to be hematocones?
Yes, they were B blasts. That's what I showed in that they were 10 negative, 34 positive, 19 positive, and they were positive for others 86 and everything. So that's why they were called as abnormal thing, and that case was diagnosed as primarily as. The message for that case was not only that we can miss that there is no need of minimal percentage of blast. That initial diagnostic clone was 0.1%, less than 0.1%. That also later appeared as a full-blown BLL. So if we gave the diagnosis of MPAL at that time only, so maybe it won't help that much for the treatment, that because the clone was very small. But we might be aware initially only. We don't need to do all these workup.
True. So there are no more questions from the chat box. Any discussants want to ask any other question? Well, yeah. Yes, ma'am. Please go ahead. You're muted, ma'am. You're muted, ma'am. Please unmute yourself. You are still muted, ma'am. No, ma'am. Please unmute yourself, ma'am.
Yeah, unmuted. Yeah. I'm
Yeah.
sorry, I'm late to. I was listening, but I was in travel, so I couldn't. So very nice presentation, Dr. Avinash. And as rightly told by one of our discussants, Dr. Amrita, we have to have proper clinical details, but especially all previous treatment history as well to correlate our flow result. I want to ask our Dr. Avinash, is there any effect if patient has received steroid before, when after that we are getting flow sample, like targeted therapy and all, we know that particular marker may not be there, and still we can correlate the result because we have the history. But many a times patient come with prior treatment of steroid. So have we seen any difference or difficulty in interpreting our results?
So, ma'am, there are documented papers and text available for post-induction immunomodulation. So they say your 34 may down-regulate after steroid, 10 may down-regulate, 20 and 45 may upregulate. So it may mimic like you're more towards mature cell. But the thing is, it should not be the 1 or 2 doses of steroid. It's a proper induction. So after induction, it will be there in normal hematogone also. It's not only the blast will show you, the normal hematogone will also show you all these changes. But when after 3 to 6 months, when you will do the repeat marrow, all these things won't be there. So there is a good publication by TMH only. Dr. Gaurav Chatterjee's paper is based on this immunomodulation and basic subset. So if you are doing more of BMRD, so there are 3-4 papers from India only. One is for high sensitivity BMRD, another is immunomodulation, and another paper is like artifacts. So what are the common mimickers or artifacts? If you go through these 3 articles thoroughly, extensively, you will read it properly again and again. You will come to know there are various changes, and that too you are in a practice. So your experience will be your experience because you are working with your flow cytometer, your reagents, your staff, how they are processing. Everything matters for the diagnosis. So after a certain time, your learning comes from your sample and your clinical discussion, your colleagues' discussion.
Very true.
So
very true.
You are senior enough. You are dealing with all these cases. You are into this phase of reporting since long. So you might be knowing that these patients are coming like this. This is the clinical presentation. This is the morphology, and here you are getting. So this may be a case. So at that time, rather than basically depend on the clinician, I directly used to call it like to the patient, and I'll talk to them in a local language. कि भाई बता दे कुछ तो खाया होगा, कोई बाबा का चूरन खाया है क्या? Basically, most of these patients, they took Giloy, Baba Ramdev's Giloy. So this Giloy is sort of a steroid. It will work like a steroid.
Very true.
And patient's fever goes down and everything goes down. And that time, what we'll get? We will get 2% blast. But with that 1 or 2 days therapy or 5 days therapy, there are not much changes what I have observed, but I really don't know about. But there is later proper data about the post-induction immunomodulation after these steroid therapies. And all the expression will come back after 5-6 months of steroid stop.
Okay. Ours is a pediatric center, so we get referral cases. And many a times patient will take some treatment and then run away to another clinic for institute for like treatment. Another question.
It happens, man.
Yeah. Have you ever come across viral infection and clinicians strongly thinking, no, you have to do like you have to do flow and give us report. We are suspecting Luke and all. So how many cases of benign like lymphoproliferation, like EBV induced have we come across?
Ma'am, I have encountered only 1 or 2 cases, but in these scenario, we have to have a proper knowledge of PIDs also. Yeah. Because these cells sometimes may mimic, if the sample is little bit dried also, no? So these cells may mimic very abnormal on morphology. Correct. And the presentation, clinical presentation may mimic like, acute leukemia. And that time, if they are like, you are dealing with ELPs. So if you are not having all these things in your mind at the time of you are analyzing your flow results, that time we may commit a mistake.
Yeah, we got one case of this thing Epstein-Barr virus, and the cells were like CD4 negative, CD8 negative, 56, and like morphology was classically looking like that of infectious mononucleosis. But our clinician wanted, no, you have to rule out, we want flow. So that was learning for us. Then we had one case, APML, clinically and morphologically thinking correct, but then it was having CD64 positivity also, along with the classical marker of APML. when this thing ETRA was started, fourth day or so, CBC came and we were supposed to see for neutrophil how many like maturation has started. Instead of that, count shoot up to higher level, and we saw all the cells looking like monocytic differentiation. And then we found like it was, instead of maturing, it was differentiating into monocytic lineage. So that we confirmed on flow as well. So that was something which can happen. Never come across like that.
So
earlier.
what was the, molecular, ma'am, whether we have gone for a proper fusion, it is normal PML RARA or some variant?
Yeah, it came PML RARA only.
Because
But
normally after ETRA, there is a differentiation and the count increase is very common. Even with the initially normal promyelocytes only increases after first 2 or 3 doses or days. Then they start appearing like converting into a neutrophil. But the monocytic maturation, this is new for me, and thank you, ma'am, for sharing your experience.
I read one article and I was very then happy. Oh, something is there. Otherwise, I was thinking, did I make mistake while I had reported it as APML, because the clinical morphologically and flow were everything fine. Only CD64 was also there. Then I wrote aberrant because I could not have correlated at that point of time. Third, fourth day, all the cells appeared monocytic. Then I was like, then we read and we got that it can happen.
It can happen. 64 can be there. The only thing is you won't have 11B. 64, basically when the cell start maturing from stem cells, so the moment they become promyelocyte or promonocyte, the 64 will be there. Okay. Then if they are going towards monocyte, then 36 and other markers start appearing. DR will be there. But if they are going towards the neutrophilic lineage, they will lose DR and 38. But again, they are having 64. So if you make a plot of 117 versus 64, you will find a very beautiful maturation, and they are going into 2 directions. So it will be like 2. One is going like monocytic maturation, the brighter one is monocytic, and the smaller one is going towards your neutrophilic series. So y-axis 64, x-axis 117, you will find a beautiful maturation pattern. And again, same pattern you can see with this 34 versus 64.
I'm still learning. Actually, we are pediatric institute.
Ma'am, everybody is learning, and you really, your case is, I learned something from your case that anybody can, face the same situation.
So for my this infectious mononucleosis, I consulted TMS Dr. Prashant, and he said, yes, ma'am, it could be that. And then I was okay, making daring to write the correct. It's not Liu, it's just a reactive and viral infection. Thank you, doctor, so very much. Yeah.
Basically, Prashant sir is my guru. I learned everything from him only. I used to bother him daily when I was doing this thing in Varanasi. So it's like that. And so basically, it's about his exposure and the type of work he's doing. So in your practice, you will learn something very different, which he might not be getting.
Yeah, ours is pediatric institute. So the ALL, AML, M7, M6, all this stuff we will be getting. Along with many PIDs also we are doing PID work.
Yeah. So basically, whenever we are doing this pediatric samples, to have this thing in mind that this can be a PID, the presentation, the ulceration, the everything can be same, and the presentation of fever, recurrent infection. PID is really, if you are not thinking, then it is a very challenging.
Yeah, we might miss it. Yeah. Thank you, doctor. Thank you so much.
Thank you, ma'am. Thank you.
Thank you. Another question from Dr. Madhura. In places where AML MRD is not very well standardized, would you recommend using it at all? Number one. And especially in the absence of PCR targetable translocations.
Pardon for the last part?
So in places where AML MRD is not very well standardized, would you recommend using it at all? Especially when the patient has got absence of any PCR targetable translocations.
Okay, so AML MRD right now, ELN also recommends that not only AML MRD, if you are going through the proper ELN guidelines, then basically, yes, we have to go through the MRD. But if it is not standardized, that time you can send your sample to another centers where they are well standardized. Right now, you can send any sample in this country within 24 to 48 hours, and it can be analyzed very easily with the basis of analysis of viability, and later on they will analyze it. So in centers like TMH or other big centers, they are receiving sample from all the peripheral areas, not only like Kunal sir. We must know Kunal sir. And they are receiving samples from entire India basically. So yes, to do the proper monitoring, because anytime blast percentage may not give you the exact result. Sometimes you may have 5, 6%, 7% hemato wounds, and you might call it as not in remission, but they may be normal hemato wound. And this is very common, particularly in 821 translocation.
For example, if the patient doesn't have NPM1 mutation, FLT3 ITD mutation, IDH1, IDH2, these are all targetable mutations. Do you recommend doing MRD in such setting?
So are we doing only MRD for targetable mutations? What is your call if your MRD is positive in non-targetable mutations?
That's why, because if the patient has got non-targetable mutations, still MRD in AML is not that standardized. What are you looking for basically, actually? So if you don't
basically
have FLT3 ID, IDH1, IDH2, FLT3, then whether to go for AML MRD at all?
So this is a basically point of debate, and people are saying yes or no both. If you are getting more than 0.1% MRD, and if you are not treating it, so what you are going to do? What is your call after that? Whether you are going for transplant, whether you are going for a reinduction after relapse, how you are going to monitor your therapy. So basically, what is MRD? MRD is just like a monitoring of your therapy. The entire call is based on the treating physician, whether how he is going to treat the patient. The guidelines are there for the centers who can have everything. But if you are sitting in a remote place, the patient is not affording. We are also facing the same challenges. The patient is not able to afford 5,000 rupees also. How can I say that ask him to go for a 15,000 test? So that time you will have a call basically based on your clinical descriptions and your presentations, and you will just do a marrow. You will see yourself that yes, there are no blasts, less than 5% blasts. Okay, we'll continue with this sort of a treatment.
True. Thank you. Another question from Dr. E. Montent. How can clinicians differentiate between whether it's false positive MRD or false negative MRD?
He's asking from clinicians. This is question for you.
So I don't know. I also can't ask him whether it's false positive or false negative.
So nobody can say this is false positive. If the only person who knows this is false positive or false negative is the person who is reporting it. And sometimes if a person by mistake is reporting, later on after the result, like if they are giving false negative by mistake, and later on patient relapsed, full-blown relapse, and the sample again came back, and we'll go and again see the previous MRD files. That time we may come to know that we missed it. True. That can happen.
Absolutely. Another question from Dr. E. Monten. She wants to know what are the clues of diagnosing APML on flow cytometry.
So on the APML, whenever you are doing flow cytometry, so it is not a diagnostic test for APML. The basic first thing is your morphology. That too, if you are having a cluster like teardrop pattern, I showed you that 45 scatter plot with that various regions, that what population is sitting where. So in neutrophilic zone, your APML population will be there. Then too, they will be having 33, which is homogeneous, 13, which may be heterogeneous. People say in books it is heterogeneous, but 13 will be there. They may be positive for 15 also because it is arising from promyelocyte. Usually they are negative for 34, or if it is present, it is only in subset. So basically APML is a diagnosis based on a high scatter blast with 34 and DR negativity, and positivity for 13, 33, sometimes 64, and negativity for 11B.
True.
Some cases in microgranular, you may find a subset of 34 positivity, CD2 and CD9.
Perfect. Thank you. Dr. Jyoti Sawhney, ma'am, your question, please. Your question.
Dr. Avinash, very nice presentation. Sometimes we get morphologically myeloid leukemia, myeloblasts. On IPT, we get myeloid markers, but then we also get sometimes cytoplasmic 3. And then we are confused whether this cytoplasmic 3 is non-specific or should we give it weightage and call the case as early precursor TALL. So what is your criteria for cytoplasmic 3 estimation?
So ma'am, what is the frequency of getting this cytoplasmic CD3?
Occasionally, not all the time.
Occasionally. So if you are refining your population very clearly, because in cytoplasmic processing, some of the granulocytes, they will lose their scatter, and other blasts, they will lyse and they will lose their properties and they will merge with the lymphocytic population. So that time, and otherwise, if your cytoplasmic CD3 positive population is showing any other aberrancy, it should not be only cytoplasmic CD3, whether they are 7 positive, whether they are 5 positive, whether they are 2 positive, and what is the percentage of that. Ideally, recently, in recent WHO and recent publication by Brentwood, they said that it is not the strength up to the brightest, which was there in previous WHO. Now it is the strength, it is just like 50% of that strength. Like it is coming in between. So if it is reaching up to the strength of 50% of your MFI of your normal T cell population, that cytoplasmic CD3 you have to consider as positive. But you have to see whether they are proper blast, abnormal cells with the other aberration also. Because if cytoplasmic CD3 is positive, then that cell must be positive for other thing also, whether they are positive for 117, they are positive for CD7, CD2. At least one T cell marker must maybe there.
Thank you. Thank you very much.
Yeah.
Thank you, ma'am. Dr. Akshay, you had another question?
So just there was a case where out of all the T cell marker, only the lineage marker, cytoplasmic CD3 was positive, and it was a good positive. It was not a borderline or dubious case, but CD7 was negative along with all the other markers, and myeloid markers aberrancies were there, 13, 33, 117, and 79A. So what are your views on CD7 negative ETPLL with no other T cell marker expression?
See, these are the rare cases. These are not the routine cases. So sometimes, like we have seen a lot of impulse when we were working, right? And that time also, so if cytoplasmic CD3 is not there, then it is an ambiguous lineage. But if it is showing more than 2 markers of myeloid lineage along with cytoplasmic CD3, so your lineage is defined. You cannot say this is lineage negative. This is lineage positive. Even though if it is showing you myeloid markers, but it is showing you the lineage marker, so it is fitting into the criteria of ETPLL. ETPLL won't say that you need 7. They say you should have lineage marker. So this case is fitting into the criteria of ETPLL. Now the frequency of these sort of scenarios, so anytime you can have some different aberration cases, but you can see the other marker presentation, because CD7 is one of the earliest marker in T cell maturation. Then 2 and 5 comes. So if CD7 is negative, that means it is a very early cell. So I think you can suggest a molecular analysis also, because there are various fusions coming up, and that too with the DNA analysis, you will come to know whether this is a what sort of a fusion or molecular aberrancy, because you have to label it as ETP. Once cytoplasmic CD3 is there, there is no other option, because ETP can handle all the myeloid markers.
Thank you. Any other discussion? Want to ask any other question? Well, so there are no more questions from the even chat box and no more hand raised signs. Well, thank you so much, Dr. Avinash, for that fantastic lecture, superb lecture, I may say. It was really eye-opening for all of us, and we learned a lot from you today. And what a wonderful discussion we had with you. Thank you so much for being with us.
Thank you. I also learned a lot during this discussion and everything. So it's my pleasure. And it's like I learned something with the discussion, and recently the Akshya told that they are rare cases anybody can have. So with this discussion, we all learn. So it's a learning for me also. And thank you. Thank you for the opportunity. And thank you. Happy Ganesh Chaturthi to all.
Same here. Thanks a lot.
Bye.
Meet you tomorrow at 11:30 a.m. Bye.
Yeah. Bye.